So there's a question about a lady who's had previous treatment with chemotherapy for breast cancer 15 or 17 years ago, and could that treatment have been a factor in subsequently being diagnosed with CLL 12 years later? The answer is probably not. We know that chemotherapy is associated with what we call second malignancies, or the development of other cancers in the longer term, but it's not thought to be associated with the development of CLL particularly. So best answer would be very unlikely. Okay, if someone wants to stick their hand up, that's fine. Otherwise, I'll just move on to the next written question. Some of the handwriting is much better than mine, that's for sure. So when a CLL patient has a blood test, the investigation results are given out, but in layman's terms, what do you look at to make sure the blood is keeping level? So the short answer to that is the most important parameter, the most important thing on your full blood count is your lymphocyte count. Now that falls under the white cell count. So if you want to keep it really simple, just look at the total white cell count. And if you've got CLL, then your lymphocytes will be the major component of that number. So for example, your white cell count may be 50 and your lymphocyte count may be 45. So if you've got CLL, your lymphocytes are the majority of your white cells. So looking at the number is important, but I'd encourage you to look at the trend of the white cell count, and it will jump around a little bit. You might have a count of 41 month and a count of 62 months later, and then it may go back to 50. So I wouldn't get too anxious or worried if the white cell count appears to jump up. Other factors can affect it, like infections and operations and other drugs and various other factors. But just keep if you're interested, you might want to keep an idea of the trend. Draw a little graph or keep a series of results to look at the trend. So if you're going 40, 80, 160 over 6 months, then that means something really is moving and your CLL is probably going to need treatment. If you're going 40, 50, 60, 47, 52, then you're pretty stable. Some patients get a little bit fixated and concerned about the absolute number, and I try and encourage them just to take a bit of a step back and just look at the trend and accept some variability and look at the trend. So the white cell count is the most important, but also look at your hemoglobin, which is your red cells, tells you whether you're anemic or not, and also your platelets to see whether your platelet count is falling, which might lead to bruising and bleeding. So white cells, hemoglobin and platelets and trends. That's probably the best way to answer that one, I think. And then a question relating to how you conduct your life. Can you lead a normal life with when you're diagnosed with CLL? Relating to moving house, travelling abroad, continuing exercise, pushing boundaries. That's the kind of the bones of the question. I would always encourage patients, certainly a patient who's newly diagnosed, not having treatment, just to lead a normal life really, and you're never going to forget about the diagnosis. It's always going to be at the back of your mind or sometimes the front of your mind, but just try and get on with life normally. You have to be mindful of infections. You might want to do little things to help, like take vitamin D over the winter, which probably helps the immune system a bit, we think. Get your vaccinations done, and there's a couple of questions about vaccinations later, but certainly the seasonal flu jab, certainly pneumococcal vaccination, sometimes Haemophilus or Hib vaccination. Try and get your immune system in good shape before the point of needing treatment. But otherwise, do what you would like to do. Travelling abroad is not usually a problem unless you're on chemotherapy, in which case it usually is a problem. But discuss that with your doctor. Exercise, do whatever you would feel able to. Do what your body, listen to your body, do what you feel your body tells you to do. So I wouldn't restrict yourself as such just from having CLL. Just try and get on with life normally, and that helps psychologically as well. And then there's another question related to that, to do with mood swings and what happened. Any advice on a patient with CLL having mood swings? I haven't really got much advice about that really medically, but it might be that the mood swings are related to the psychological aspects or the anxiety of coming to terms with the diagnosis, and that maybe where CLLSupports Association, family, friends, other bodies like Maggie's may be able to help and getting information that you need. But there's not really a medical explanation or solution to that, I'm afraid. Okay, Next question is, typically when would you see P53 mutate after diagnosis? So I'm trying to answer this. So I think what the question's asking is there a particular time or is there a particular time when P53 may become mutated? Well, actually what we think is it's probably mutated there in a small number of cells from quite early on. It can be acquired, so having treatment for CLL can cause P53 mutation to become apparent down the line. But some patients, for example, have a P53 mutation in 0.01 cells, so maybe 1 in 100,000 cells, and we just can't find it at diagnosis. So it's there at the beginning, but it becomes more apparent as that particular cell population grows and is resistant to treatment, and then is easier to find later. So it's not so much that, I think for most patients it's probably there as what we call a subclone, as a tiny population of cells amongst the rest of the CLL cells from early on in diagnosis, but it just manifests itself and becomes easy to find and apparent years down the line, usually after treatment. So that's probably the best way I can answer that one, if that makes sense. And the second question from the same person is, which drugs are out there but yet to be licensed and funded? There are not, okay, so there are drugs in development that are close to getting a license which are alternative BTK inhibitors. So I mentioned ibrutinib a number of times. There are second generation drugs which are very similar to ibrutinib, but probably a bit cleaner in terms of their side effects, or less side effects, and possibly more effective, but that's not been proven yet. So for example, there's a drug called acalabrutinib, that's probably the second in line, which has got a license in the States for a different type of lymphoma, and a drug called zanubrutinib, and there are various, and another drug called vicabrutinib. So there are various versions of second generation sons or daughters of ibrutinib that are in development. And they may prove to be better tolerated with less side effects, and they may prove to be more effective. Some of them are quite close to getting a license, but they're not there yet. They're in the pipeline. Then there is a combination of drugs that I mentioned, both of which are used separately. So venetoclax plus obinutuzumab. Those drugs combined have been licensed in North America as first treatment for older patients with CLL, but they're not yet licensed in the UK and not yet funded. So again, it comes back to the evidence, the licensing and the funding that I talked about before. There are lots of things in the pipeline. Some of them are there but not quite funded yet. Some of them are not yet licensed, but there's certainly a kind of a rich array of drugs coming through. And it'll be quite difficult for us to decide how to use them and how to pay for them, but there's certainly a lot of movement. So a question about long-term neutropenia after treatment with FCR. It occurred after chemotherapy, and it's been a problem for several months, needing GCSF, or is GCSF the long-term solution? The answer is that if you have neutropenia which is persistent or recurrent in the months following FCR, it's probably a hangover, what I call a hangover in layman's terms, from the rituximab. Rituximab can cause an indirect, rituximab doesn't target neutrophils, but it can cause an immune-mediated, it can cause the immune system to destroy neutrophils. And that problem can go on for months after FCR, but it usually gets better. So in most patients have GCSF on and off for a number of weeks or months, and it finally sorts itself out. Rituximab takes months to wash out of the system, so usually once that happens, it gets better. Occasionally we need to use other treatments like steroids or other immunosuppressive drugs like cyclosporine, but that's quite unusual. So I would probably say to be patient, wait a bit longer, have your GCSF, and it should get better eventually. But obviously I don't have all the details, but that's my gut feeling on that one. So it could be autoimmune, so your suggestion was correct. There's a question here about vaccinations, I think. Could I have the meningococcal vaccine? I think this is what this one's asking. The answer is that nearly all vaccines in CLL would be encouraged as long as they're not live vaccines. So the shingles vaccine is not recommended because it's not, it's a live vaccine and it's not being tested in CLL. So some of my patients with CLL have had the shingles vaccine from their GP. and nothing's happened, and that's okay. So don't worry too much if your GP's given it to you without the knowledge. But as a general rule, we don't recommend shingles, and we don't recommend other live vaccines. But all the other vaccines, pneumococcal, Haemophilus, seasonal flu, meningococcal would be fine. So any non-live vaccine would be encouraged. And this person's daughter, who's 16, has been offered the nasal flu spray. Now, the nasal flu spray is developed for children, so they don't have to have the jab. My girls are a bit smaller, and they have the nasal flu spray. But that is a live vaccine, and there's a potential risk of catching the flu then in the days following your daughter having the nasal flu. And the question is there any reason why she can't have the non-live flu vaccine? And the answer is no, as long as she's happy to be jabbed in the arm. So there you go, you can sort that one out with her. Okay, question about diet. So a few questions now about kind of diet and alternative or supportive management, I would call it. Some patients advise that vegan or low carbohydrate diets help to prevent CLL symptoms. Is there any scientific corroboration of this? Short answer, no. But there's nothing to stop you having a healthy vegan low carb diet if you wish. I think the general advice about diet and CLL is just be healthy and just eat things you like in a sensible, healthy way. There's nothing specific for CLL that I'm aware of. Vitamin D that I mentioned a few minutes ago is probably the only thing that I say take some vitamin D supplementation, particularly when the clocks change in October and the sunlight goes down. We all need some vitamin D. So apart from that, there's nothing really specific. I mean, if you're having chemotherapy or immunosuppressive drugs, then imagine you're pregnant and avoid, shellfish and non-pasteurized cheese and things like that. But just common sense probably is the short answer to diet. There's a question here about, I'm not quite sure what one of the words says, but it might be integrative medicine, which seems to be used in the US more than in the UK, i.e. for reducing side effects and enhancing effectiveness of drugs. I'm not aware of any evidence, scientific or medical evidence, that would suggest that taking one of these medicines to reduce particular side effects or improve effectiveness. I don't think there's any good evidence to support that. There's lots of stuff, as you can imagine, on websites and from different people and companies promoting these kind of approaches. I'd be rather sceptical about those, and would like to see some stronger evidence. And similarly, what are your thoughts on alternative treatments? I generally have an open mind. I mean, if a patient wants to take a herbal remedy or pursue an alternative treatment, as long as we know what it is and it doesn't interact with their drugs, or if there are drug interactions with ibrutinib and venetoclax, so even simple things like cod liver oil, vitamin E, various other things can interact with ibrutinib, and we would advise against those specific things. But as long as we know about what those alternative treatments are and there's no direct clash with the drug, then I'm not opposed to it. I keep an open mind. Some people believe in turmeric and various other things. It's not a problem. If we know what it is, if it doesn't interfere with the drugs, it's fine. But I wouldn't hang too much weight on it, and I would also stick to the conventional treatment alongside it. Hyperbaric chambers for red cells. I don't think there's any role in CLL, so I think there's a lot about this. But I think some of these hyperbaric oxygen and various, I mean, there's always a commercial element to these factors that you need to be mindful of when you're deciding whether this is useful or not. So I'd be very sceptical about that. Insect bites. Does having CLL make somebody more susceptible to insect bites? Somebody gets bitten a lot in the summer every year. Well, I don't think you can blame the CLL, but maybe something you're eating. Serious answer is I'm not aware of any evidence or rationale why the insects may prefer to bite you rather than somebody else. Right, a couple of specific questions about treatment. What is your preferred second-line treatment after FCR has failed? And this particular patient is not P53 or 17p deleted and has unmutated CLL. I think it's fair to say that most clinicians in the UK would generally use ibrutinib in this situation. unless there was a specific reason not to use ibrutinib, so a heart problem, particular heart problem, not all heart problems, but particular cardiac arrhythmias and rhythm problems, bleeding problems, some particular drugs. They may be reasons not to use ibrutinib and to use either venetoclax, rituximab. That would be another option. Ibrutinib is most commonly used. Venetoclax, rituximab is challenging ibrutinib. And it comes down a little bit to some of those things I talked about earlier, which is the concept of continuous treatment with ibrutinib, which could be for a number of years with some of those side effects potentially, or having venetoclax, rituximab, a little bit more involved in the first month, 2 months, and potentially better tolerated after that. It really comes down to an individual decision. Both are effective. Ibrutinib is more commonly used. If ibrutinib subsequently fails, you can use venetoclax. And if venetoclax subsequently fails, you can use ibrutinib, so you're not compromising your third line option of treatment. So it's just something to really openly discuss with your doctor and see if there's anything specific about you or your health or your preferences that may steer you to one or the other. But it'd be one of those. I wouldn't use CLLSA unless it was really a good reason to do that second line. And of course a trial if there was one available. And then a similar question, but for someone who's a patient who has a P53 or 17p deletion, who has ibrutinib as their first treatment, what is their option for second line treatment for that patient? And the short answer to that would be venetoclax plus rituximab. So if ibrutinib fails, so if CLL becomes resistant and progresses on ibrutinib, then idelalisib is less likely to work because it works in a similar way. Whereas venetoclax works in a completely different way to ibrutinib. So if you have P53 deletion and you have ibrutinib and then relapse and develop resistance, then as it stands in 2019, then venetoclax rituximab would be your best option. And then if you're young enough, and that might be then when you start talking to your doctor about the possibility of a stem cell transplant, because of the number of drugs after venetoclax then options is becoming smaller. So it's just something to potentially have on the horizon in this particular scenario. Right, and then a couple of questions on the last page here. One is relating to is it possible to restore your immunity after treatment? So that's a good question. Ignore the big one, okay. So just the top two. So the possibility for restoring immunity after treatment. It's a good question. It's quite difficult to answer, I suppose. There are different elements to your immune system. So if you take FCR as the first thing to say is that CLL itself will affect your immune system, even without treatment. So it might affect your antibody production, so your immunoglobulin levels might be lower. It can also affect your T cell function, even though T cells are a separate cell to CLL, it can affect how well your T cells work. So even at baseline, when your CLL is active, it can affect your immunity. So sometimes treating CLL can actually, per se, can improve the immune system. However, if you're having FCR as your treatment, that will, at least temporarily, for months or a year or two, will make you more susceptible to infection. So fludarabine is very good at wiping out your T cells or making your T cell function very low, for numbers very low for a while. And that's why you need to take drugs like acyclovir to prevent shingles, and drugs like cotrimoxazole to prevent these, or Septrin to prevent chest infections. So in the short term, FCR will wipe out your T cells and rituximab will hit your B cells quite hard. So your antibody levels and your B cells are low. So you could go from a situation with having CLL, of having a lower immune system because of CLL, having FCR knocking you down and having lots of preventative antibiotics. But then when you recover from the FCR, your T cells will recover 6, 12, 18 months after FCR. Your B cells will take a year or two to recover. You may be in a position then where your immune system is better than it was at the beginning. In the meantime, there's not much you can do apart from be mindful of maybe have a low threshold for treating infection, take your preventative tablets, the relevant ones I mentioned. Vaccinations don't work after rituximab, certainly not for 6 months after rituximab. So if you're going to have if you're having rituximab now, or you've had it in the last few months, then you can have the flu jab, but it just won't work. There's good evidence to say that it just won't do anything. So it's more important in that situation for your family to get jabbed. So get all your close family and friends to have the flu jab to kind of protect you a little bit from transmission. Whereas if you have a drug like ibrutinib, there is good scientific evidence and some clinical evidence to say that ibrutinib treatment of CLL does restore your immune system function certainly more quickly. So FCR knocks it down, takes a while, comes back. Ibrutinib probably lifts it more quickly. And funnily enough, ibrutinib seems to improve the function of your T cells, which are separate cell. They're not really anything to do with your CLL, but they talk to each other, being T cells. Controlling your CLL and getting your CLL into remission improves the function of other parts of the immune system. So that's a very long answer to your question, but it is quite complicated. It's quite complicated. And then the other one, which is a very hard question as well, is explain BTK inhibitors. So ibrutinib is the first in class, the first drug that we call a BTK inhibitor. The best way for me to explain it is that you have the CLL cell, you have this really important molecule that sits in the CLL cell called the B cell receptor, and that receives signals from the external environment and signals from other cells, and it acts as a signaling molecule. So the B cell receptor is signaled, so let's say it gets a signal to say, grow more, please, grow faster, proliferate, divide, and then it sends that signal to within the brain of this down a kind of a chain. It's like a Chinese whispers or something around a room, a chain of messages that go down through different molecules in the cell that then lead to the growth, survival and proliferation of that cell. Now, one key part of that chain of signaling is this enzyme called BTK. It's interesting, it was discovered actually because there's a condition where there's an inherited condition in boys where they're deficient in BTK, and those boys who are born, it's a very rare genetic condition, if they're born without BTK, they have very low numbers, if any, B cells, so they have virtually no B cells at all. So that was one of the things that made, when we were working out how important BTK was, that make us think that actually targeting BTK might be quite good at reducing the numbers and function of B cells. So BTK is a part of this chain of signals downstream of the B cell receptor, and so by targeting that chain, it's like taking out a loop in a chain. The signal can't be transmitted, and so the B cell doesn't have that signal that it needs to grow and survive. Does that make sense? There you go. That's about as well as I can do.
I've got a quick question. You keep talking about taking vitamin D supplements. With CLL, do you get deficient vitamin D?
No, so no, CLL in itself doesn't cause vitamin D deficiency. But the reason I mention it is because actually, once the clocks change in October and it's dark most of the time, and most people in this country, or many people, a significant proportion of normal people in the Northern Hemisphere countries, including the UK, will be vitamin D deficient. We've known that for a while. We know vitamin D is important for other parts of health, bone health, and various other things. But in recent years, it's become apparent that vitamin D is important for immune system function. We also think it helps some drugs like rituximab work better. And some of that information and learning has come from some of the non-Hodgkin's lymphomas, the follicular lymphoma and other lymphomas, where we think vitamin D is important at helping B-cell lymphoma treatments work better, but also in terms of improving immune function. And so I mention it a lot for CLL because patients with CLL have reduced immune function for different reasons and are more susceptible to infections. And it's just something simple you can do. We know that we're going to be vitamin D deficient, most of us, in the winter, and it's cheap to buy a bottle from Sainsbury's or wherever you shop, and it's just a really easy, simple thing to do that might help your immune function. So that's really why I mention it. It's not a magic solution to everything, but it just might lift your immune function a little bit over the winter. Yeah.